Good afternoon. My name is Mike Masding. I'm co-chair of the UKFPO, and it's my privilege to introduce today's webinar, the third in our series in this academic year. And the subject today is ethics, which is a huge part of clinical practice. I'm a consultant physician when I'm not doing my UKFPO work, and I come across big and small ethical dilemmas all the time, and you will throughout the rest of your careers. I'm delighted to introduce Laura Machin, Phil Spencer, and Lena Hamad from the northwest of England, who are going to take us through some ethical decision making and how they will see that for foundation doctors. I hope you enjoy it. There's the opportunity to ask questions if you put them into the Q&A tab on your Teams in front of you. I should also point out that this webinar is being recorded and will be available on the UKFPO YouTube channel and website. I'll now hand over to Laura, Phil, and Lena, and look forward to what they have to say.
Hello, everyone. I'm just going to share the PowerPoint presentation now. Right, can we see the screen? All right, fabulous. Yep. Okay, great. So I guess I'll be starting with a few questions that I felt I had to resolve in my mind as I learned about and became more interested in ethics. So my first question, I guess, is directed to you, Phil, as a clinician and as a person who sits on hospital clinical ethics committees all the time. What is medical ethics?
So medical ethics is an example of applied ethics, and it's the study of what makes things right and wrong. It's the study of what we should do and why we should do it. Doctors are forced into making both clinical decisions and, as Mike said, ethical decisions on a pretty much routine basis. Clinical decisions are based on matters of fact, in that you can look up the answer if you're not sure. You can look it up in a textbook, or you can ask an expert, or if nobody knows the answer, with the advancement of science or setting up a suitable experiment, you can determine the answer. In contrast with ethics, where you can't just go and look up an answer because the answers entail a degree of value judgments. You can't determine the answer by experiment or by the advancement of science. What you have to do is to use rational argument and logic to try and reason your way towards a decision. And that is the process of ethical reasoning.
Okay, so I know that ethical training is a very important aspect and it's very crucial for us as foundation doctors. Laura, can we talk a little bit about why that is?
I mean, given that we're here today with the UKFPO, I suppose I need to say, obviously, that the curriculum tells you, the Foundation Programme Office tells us that it's important. To be fair, though, your peers as a foundation doctor yourself, Lena, have also told us that ethics and law and professionalism learning really matters. We did a national survey of foundation doctors back in 2018, and admittedly, only 479 replied responded to that survey. But it was really clear the message we got from foundation doctors from that survey, which stated that there are some topics that they believed should only really be talked about and receive training on during that foundation programme. And it was suggesting to us that there are some topics that undergraduate curriculums just aren't required to deliver. And actually it does need to be when you are a foundation doctor. I think, to be fair, though, in the literature, the research literature around medical ethics and resident doctors, in particular our foundation doctors, I think the idea that there ethical issues do arise more frequently than most medical students or foundation doctors perhaps anticipate during that foundation programme time. And I think, even though I am obviously at medical school and I am involved in undergraduate teaching to medical students, no amount of undergraduate teaching is ever going to be able to cover and set up our resident doctors for the rest of their career. You do need to have training during that foundation programme time. And like Mike said, really beyond that foundation programme as well. And then finally, I think it's clear from the research that we have available to us that foundation doctors do experience ethical issues differently to that of perhaps a medical student, or perhaps of more experienced resident doctors. And that's based on their position in the organisation, the medical hierarchy that can exist in some trusts, and also really the transient nature of foundation doctors moving on every 4 months, different placements, not really being able to ever really truly embed within a team, and not really necessarily building those relationships, those safe, secure relationships, in order to start the more deeper learning that comes from role modelling, perhaps, whilst on a placement. So we do need to do particular training for foundation doctors on ethics and law and professionalism, in my humble opinion.
Yeah, I think I do agree with you on what you said earlier about us not anticipating how much ethical situations or ethical scenarios we might find ourselves in. Especially, at least for me, I think we assumed, especially during the early stages of my training during F1, that as foundation doctors, we might not be involved or particularly responsible for making big ethical decisions. So things like setting your ceilings of care, or, for example, whether a patient or not needs to be placed on a ventilator. So is ethics, isn't it all about the big decisions, this stuff that we need to consider in clinical practice?
Yeah, I mean, as you say, it is about the big questions like, should we ventilate this patient? Should doctors participate in assisted dying? Which clinical service should be funded and which shouldn't, and so on. And foundation doctors may well feel that these conversations don't directly impinge upon them, but you have to remember that every clinical encounter has an ethical element to it, but it often goes unnoticed because there's usually a fairly clear and uncontentious way forward. So everyone's in agreement with what's supposedly the right way forwards. But the ethical dilemma creeps in and becomes more apparent when there's a divergence of values, or when people disagree about what is the right course of action or the best course of action, or perhaps when a patient holds a different opinion to yourself. For example, the patient may refuse treatment that you feel to be in their best interests to receive. Should you give an antibiotic to a patient with dementia when they're refusing it? Should you withhold a piece of information from a patient? These are common day-to-day questions and decisions that may well come the way of any clinician from the moment of graduation onwards. But they do often go unnoticed and uncontested. But nevertheless, they are ethical questions and they should be weighed in the balance. So developing an ethical awareness and an ethical sensitivity is really important right from the outset, from foundation upwards. And keep in mind that there are very few blanket rules as to how these sorts of situations should be managed. Even though they may be seemingly routine situations, each situation must be judged according to its own specific circumstances. Sometimes you should do one thing, sometimes you should do another thing. But what is it that determines the right choice in any one particular situation? And that is the process of ethical reasoning coming into play. And every clinician of any grade should have a sensitivity and an awareness of when they're encountering an ethical dilemma.
Right. Well, if we think about how we are in an everyday to-day basis, we're on the wards most of the time. We've got a long list of jobs that we need to get to. And sometimes it can be tempting to rely on our instincts when making these decisions. So we all have a sense of what's right and what's wrong. And is it enough to solely rely on our intuition when it comes to these situations, or is there more of a structured approach that we should follow?
Yeah, past practice and personal intuitions are obviously really useful in guiding our decisions, and they do speed up our decision making, and that's what we rely on for most routine decisions. But the problem is that they're no guarantee of good practice, and furthermore, other people may not share the same intuitions as ourselves. And bear in mind that reliance on past practice and intuition is not necessarily based on logic and reason. It's unconvincing to argue to a patient, to the coroner, to a colleague, to a relative, that a decision was right because that's the way we always do it, or because simply that was the obvious thing to do at the time. That is unpersuasive. It gives no basis for persuading or convincing other people of why we did the thing that we did. We need to be able to say why something is right and why something is wrong. And decision making needs to be tailored to each situation, because each situation is different and usual practice may not always be appropriate. So an understanding of ethics gives you the vocabulary and the concepts to weigh your options and justify your choices. So to go back to your question, Lena, and to address your question about whether there's a structured approach, that there is. And there are structured ways of structuring or thinking about ethics. And the 4 principles, or 4 Ps as it gets abbreviated to, is probably the most widely recognized way of structuring the way we think about ethics. And I think we're going to talk about the 4 principles in a bit more detail in a minute.
Okay. Laura, as an ethicist, I think you might tell me that solely relying on the fact that we know the law is not enough when we're navigating these clinical scenarios or situations.
Yes, you're right, Lena. I mean, ethics doesn't really occur in a vacuum. I mean, of course, as doctors, you must think about what the law allows and doesn't allow. You obviously need to bear in mind what the GMC says, and that may well give doctors an answer, but often not. And also, to be fair, you might not always be clear, or it might not always be immediately clear how you should interpret and apply that guidance. And this is where the ethics bit comes in. And then when you think about the GMC and the law, these all have to come from somewhere, and that somewhere is the ethics. So bearing in mind, we've now got a foundation doctor, we've got a clinician who's also teaches ethics and law, and we've got myself as an academic. Why don't we apply all this to a scenario?
Yep.
I'm going to allow people to have a read of the scenario. So the on-call F2 doctor has attended a discussion with Mr. M. In the course of the conversation, Mr. X says that he's quite happy to sign whatever form is needed, but he is going to leave. So the F2 is uncertain of her responsibilities and whether she should become complicit in helping him to leave by prescribing cardiac medication for him before he goes. So Lena, as our foundation doctor who's in the 2nd year of her training, what do you make of this?
So this is a very familiar situation for me. On one hand, it would leave me feeling that I'm a bit worried about this patient and what might happen to them if they leave. At the same time, it also makes me feel like I'm a bit uncertain about the extent of my responsibilities when it comes to the situation. So should I let him leave to begin with, even though he still requires care, obviously? And should I be complicit in enabling his departure by prescribing these medications for him? But then on the other hand, there's clearly no reason why I should question his capacity, at least from this scenario. He's made his decision and he's signed the form. So it can be tempting to think what really is the problem here.
Or even, to be fair to you, perhaps, like, where's the ethics in all this? Where are the ethical issues? Now, Phil, you've had a long medical career. Have you seen a difference in how medics would typically treat somebody wanting to discharge themselves over the years?
Yeah, absolutely, for sure. I mean, when I started out as a house officer 30 years ago, I would suggest that it would probably have been common practice for the resident doctor or house officer, as they were then, to in a situation like this, perhaps heave a sigh of relief and think, that's one less patient to have to deal with. And you let the patient go and simply record it in the notes that the patient has decided to leave. And that would have been considered common practice and probably would have been it. But as we've said already, common practice is no guarantee of acceptable practice, let alone good practice. And nowadays, just letting him leave with little or no discussion would be considered ethically unacceptable, quite apart from being legally inadequate. It's not that ethics has changed over those 30 years, but we have become far more ethically aware, and the law has evolved to reflect that. So just getting him to sign something and letting him go would not be sufficient, either morally or legally. We actually have to do more than that.
Okay, so thinking about the ethics then, like Phil said earlier, we've all heard of the 4 principles, the 4 Ps, which is the respect for autonomy, beneficence, non-maleficence, and justice. Now, if we take autonomy first, I think we'd all agree how important it is that we're in control of our lives. None of us like to think that we're losing control of how we live our lives. Right now, the duty to respect autonomy is the bit that tells us that we must respect his choices as long as they are autonomous. And it's also the bit that empowers him, this patient, rather than allowing doctors to impose their views or values upon them or impose common practice. It's also the bit that protects the patient and really essentially from unjustified paternalism. But what about beneficence, Phil?
Yeah, so as you say, respecting his autonomy requires that we respect his wish to leave, provided it's a genuinely autonomous choice. Beneficence, on the other hand, is the positive duty to maximize benefit, or alternatively, to minimize harm. So taking the first bit of that, applying our duty to maximize benefit to the case of Mr. X in our scenario. This is the bit that imposes a positive duty on the doctor to be proactive in working for the benefit of the patient. In other words, although autonomy dictates that the patient is the decision maker, the doctor still has a positive duty to help and empower the patient to make choices that are right for themselves and to help them make truly autonomous choices. This immediately tells us that we should be we would be neglecting our moral duties if we simply let the patient walk out, even though that may be his supposedly autonomous choice. Our duties and responsibilities actually go further than that, further than being simply a passive provider of care to those who choose to accept it. We should be helping patients to make wise choices that they believe are the best things for them. Note that our duty of beneficence doesn't extend to actively overruling his choice to leave, provided his choice is a meaningful expression of his autonomy, because in Western medicine, at any rate, we would normally prioritize the principle of respecting autonomy over our duty of beneficence. So that's the bit about beneficence, meaning maximizing benefit. But beneficence is also about minimizing harm. So if our patient, Mr. X, remains determined to leave, we must also think about what steps we can take to try and mitigate any harmful consequences of him taking his own discharge. And this might include, for example, taking steps to advise about what warning symptoms to look out for, and assurance that he can return to the department if necessary.
So autonomy then requires doctors to respect the patient choices, but that alone isn't enough, is what you're saying. So doctors don't leave patients to make unwise choices, essentially. The beneficence requires doctors to help them make wise choices.
Sure.
Can we delve a little bit deeper into how the principles of beneficence and non-maleficence differ? So to me, sometimes they seem like they could be overlapping concepts, but I do wonder whether they impose different obligations on us.
Yeah, so I mentioned that beneficence imposes positive duties on us to do certain things, i.e. that we work to maximize benefit, minimize harm, and so on. That's a positive duty to do something. Non-maleficence, on the other hand, imposes negative duties. It imposes a duty to avoid doing things that will actually cause net harm. And so that's slightly different to actively doing things to minimize harm. So perhaps to give a simple illustration of that distinction between beneficence and non-maleficence, our duty of beneficence would suggest that we all ought to be proactive in doing our bit for charity, for example, whereas non-maleficence would suggest that we ought to avoid buying cheap clothing that's made in a sweatshop that exploits child labour. So one is a duty to do something, the other is a duty to avoid doing things. And applying that to our self-discharging patient, our duty of non-maleficence would suggest that we should avoid resorting, for example, to threats or coercion as bargaining tools to try and persuade him to stay, because doing so would erode the voluntariness of his choice, thereby undermining his autonomy. Similarly, we must avoid acting in an antagonistic or an obstructive manner because we're angry with him or whatever. We must avoid meting out any form of punishment by being awkward. We mustn't be motivated to discourage his return to the department if he deteriorates, and so on. So beneficence and non-maleficence do impose very different obligations on us, and they're not just different ways of saying the same thing.
Okay, thank you for that. That clarified it a bit. Moving on to justice, I know there are two strands to justice. We've got moral justice and we've got legal justice. Can we talk a bit about those as well?
Yeah, so perhaps if we take moral justice first, it perhaps has somewhat less relevance to this particular case. But generally speaking, it's about issues of fairness, it's about rights, it's about resource allocation. And if we do apply it to our present case, it perhaps reminds us that we've got a duty to avoid needless waste of resources, be that your time, a hospital bed, or whatever it might be. But you must be careful about how you determine what counts as a needless waste. Just because you feel that your self-discharging patient may be wasting your time doesn't justify you in making a moral judgment that he's not deserving of necessary care. To do so may be very unfair to the patient and a violation of his rights, for example. Similarly, what right do we as doctors have to pass judgment on our patient's moral character when we know so little about them? We know little about their circumstances or the basis of their decision making. So in other words, what right do we have to choose to correct for a patient's moral failings or to punish them or to deny them access to future care? And what right do we have to use coercive measures to encourage him to stay against his will, for example?
Okay, and for legal justice, I know that this captures our legal obligations that stem from statutes and case laws. So statutes are the Act of Parliament. So, for example, your Mental Capacity Act, which allows us to determine whether a patient has the capacity to make that particular decision or not. And if they don't, then how should we proceed? Your case laws, if I'm correct, these are laws that have been built over hundreds of years, and they create binding precedents. So this is, for example, where our laws on negligence come from. And it states that we must fulfill our duty of care and that this is the minimum standard that is required for us to avoid a claim of negligence. Is that correct?
Yeah, you're absolutely right. So legal justice is simply a consideration of what the law says, what it requires of us, what it permits and requires us to do and prohibits us from doing. And I would suggest that it's actually got quite a lot to tell us about how we should be dealing with our self-discharging patient. Firstly, as you said, Lena, the Mental Capacity Act, we must be mindful of whether our patient lacks capacity for the decision to refuse treatment. There's nothing in the scenario that we've read to suggest that Mr. X lacks capacity. But if he did lack capacity, we would have to make that judgment, and we would have to then embark on best interest decision making if that was necessary. So that's statute. You also mentioned case law and our duty of care. This is an area of the law that's undergone major change in the last few years, change that has significance and relevance to all of us. I'm sure that many of those listening will probably have heard of the Bolam Standard, which comes from the Bolam case in 1957. And that case determined that the reasonableness of a doctor's actions should be judged by what a responsible body of doctors feel is reasonable under the circumstances. And the ruling from that case had far-reaching consequences, and it ultimately evolved to effectively hand authority to the medical profession to decide how matters of consent and refusal should be determined. So matters of consent and refusal were judged by what doctors thought was reasonable. And that was the standard that prevailed for well over 50 years, despite coming under heavy academic criticism. The criticism being, why should doctors determine how patients should be informed and advised? Why should doctors have a monopoly on deciding how much information patients should be given, and so on? Now, that situation was turned on its head in 2015 by another case that some people may have heard of, the Montgomery case. The Montgomery ruling determined that the steps that doctors should take to advise and inform patients should actually be dictated by what a patient might reasonably expect, not by what a doctor felt was reasonable. So the Montgomery ruling places autonomy center stage and wrestles some of that paternalism away from doctors. Note just that the Bolam Standard hasn't been abandoned altogether, and it's still very relevant and just as relevant today as it was in 1957 to issues about the technical clinical decision making about what treatment is appropriate and so on. But it's no longer the legal standard for advising and informing patients about how much information we should share. So as a consequence of the Montgomery ruling, the onus is now very much on doctors to be more proactive, not just in imparting information, but also in taking reasonable care to ensure that the patient is aware of any material risks, I think is the phrase that's used in the judgment. We have to ensure that the patient is aware of any material risks, which in this case would mean material risks associated with self-discharge. So this doesn't mean that we are under an obligation to persuade the patient to change their mind, but we are under a legal obligation to promote rational decision making, and that is the standard by which we will be judged if things turn out badly. So we have to be much more patient-centered than we used to be, and we are legally required to strive to empower patients to make choices that are right for them. So there is much greater emphasis now on autonomy, but also greater emphasis on our positive duty of beneficence. So as I said before, 20 or 30 years ago, the mere act of getting the patient to sign the form before they leave may well have satisfied the Bolam standard required to defend a claim of late negligence, but that is certainly no longer the case. Since the Montgomery case, it's no longer a matter of getting a patient to tick a box or sign a form. The law has evolved to require that we be proactive in promoting autonomy as part of the process of securing meaningful consent. And this is not just an ethical obligation, it's now very much a legal requirement as well.
Okay, so would it be fair to say that a reasonable model in dealing with the case of Mr. X here would be that our duty to respect autonomy dictates that we should empower him to make an autonomous decision that is the right decision for him, but also dictates that we should seek to make any reasonable adjustments or accommodations that might enable him to stay?
So once he's reached his autonomous decision, Lena, and if he remains determined to leave, then we have to set that aside and then focus on the other duties that doctors have, which we've mentioned today so far as beneficence, and then work to enable him to self-discharge in the safest and most constructive way you can. So what would that look like then, Phil?
Yeah, so our duty of beneficence suggests that we should be proactive in enabling him to enact his decision as constructively as possible. Exactly what we should do in any given situation will be shaped by the specifics of the circumstances, but beneficence would suggest that we should be aiming at least to prescribe take-home meds for him, perhaps make sure that he knows what adverse symptoms to look out for, make sure that he understands that he can call for help at any time if things start to deteriorate, perhaps arrange follow-up, maybe even liaise with the GP, for example.
Brilliant. And so then non-maleficence reminds doctors that you shouldn't then be obstructive or coercive or punitive in your dealings with him. But then justice then, Lena, where does that leave us?
So from our conversation today, I think justice tells us that we should respect his rights and that we have no special rights really to pass any moral judgments based on his choices. We also need to be mindful of our legal obligations, but I'm assuming that by meeting our moral obligations, we are likely to have fulfilled our legal obligations as well.
Yeah, I mean, that sounds like a really good summary of what the ethics is telling us, as I understand it, and it reflects the much more patient-centered approach that the law and the GMC now require of us.
So on a practical point then of the law, then Phil, what should your doctors do about patients who refuse to engage in any discussion with doctors at all?
Yeah, I mean, some patients won't be willing to engage in any discussion, whether that's due to, being under the influence of drugs or alcohol, or just out of sheer frustration and annoyance. And there is a limit to what we can be expected to do. But the law recognizes this. You can only do your best and you can only do what is reasonable. However, you should still document, insofar as you're able, your assessment of their capacity. And remember that if they lack capacity, you've got to make a best interest decision about whether to prevent them leaving or not, for example. You should be documenting the efforts you made to negotiate with them, any reasons that they might have given for their refusal to talk to you, and why you did or did not do things to follow up, such as informing the GP, for example. I think it's important to keep in mind that self-discharging patients are high-risk patients. They are often medically unwell, and they suffer increased morbidity and mortality compared to other patients. And they often, studies have shown that they often have mental health problems, and that they are many times more likely to be readmitted with the same problem within the next 10 to 14 days. And also importantly, they're more likely to lodge a complaint or initiate legal action. So documentation is really, really important. But yes, you can only be expected to do what is reasonable. But the standard of reasonableness is not met by abdicating responsibility for his care just because he's willing to sign a discharge waiver. And in these sorts of situations, for many doctors, I would suggest that their uncertainty about what to do often centers around whether the patient does indeed have capacity to make the decision to leave. And that can often be a very challenging situation for particularly a junior doctor in trying to decide whether the patient has capacity or not. Assessment of capacity is a core clinical skill. And I think if listeners are lacking in confidence with the determination of capacity, that's something that they should perhaps think about, but would need to be addressed in a dedicated training session, I think.
Thanks, Phil. So it's worth remembering then that when you're engaging in ethical reasoning, there may not just be one right answer, and there may be a range of ethically reasonable options by the sounds of it. I think it's also worthwhile for the people listening to remember and hold on to that ethical reasoning isn't an algorithm that necessarily works out the correct response. It may do so, but not necessarily. And then ethical reasoning is an active process of weighing up options and going with the option that you feel best balances your competing moral obligations. And that may entail a degree of value judgment. But a knowledge and understanding of ethics gives you the language and principles to enable you to justify and give reasons for your chosen course of action.
Yeah, absolutely. And in this case that we've discussed particularly, there's a potential tension between our duty to respect the patient's autonomy and our duty to promote his welfare, i.e. beneficence. But generally speaking, people, all of us, greatly value having control over our own lives. So we actually place great weight on the principle of autonomy, and we shouldn't overrule people's autonomous choices lightly. And mindful of the weight that we give to the principle of respecting autonomy, in Mr. X's case from our scenario, our 4 ethical principles really point towards a fairly clear and uncontroversial course of action. But that's not always the case. Sometimes ethical principles will impose much weightier conflicting demands upon us, and that's what creates really meaty ethical dilemmas. And in such situations, we must make a choice about which ethical principle or which moral obligation we're going to prioritize over the others and why. So, as I said, we give great weight to the principle of autonomy, but there is otherwise no particular ranking or order of importance implied by the 4 principles. We always, in conversation and in the textbooks, we always have this mantra of reciting the 4 principles in the same order: autonomy, beneficence, non-maleficence, and justice. But that shouldn't be taken to imply that that is a ranking of hierarchy or importance, that the ones higher up the list trump those lower down the list. That's not the intention. Our starting point should really be that they all carry similar weight. And I would suggest that in practice, it's actually often helpful to consider what the law says first, because we must abide by what the law demands, even if the ethics takes us in a different direction. If the law tells us we must be doing one particular thing, or we must refrain from doing something else, that does trump what the ethics tells us. We must abide by the law. And the law and ethics don't always agree, but when they don't agree, it's the law that trumps the ethics.
Thanks, Phil. That's really helpful. So as we bring the discussion to a close then, Lena, as our foundation doctor, what are you taking away from this discussion?
I guess when we face these challenging dilemmas, we should probably ask ourselves, what does the law require us or permit? And what does the GMC say about this particular situation? And to think about what moral demands are imposed by the 4 principles of ethics. And then we can use that as a starting point for our deliberation, essentially. as Phil mentioned, there may be more than one justifiable option depending on the situation that you're in. But the main take-home message for me is that ethics is probably not always about giving you the right answer, but more of a means of applying the logic and reasoning to your thinking so that you're able to justify why you've done what you've done.
Brilliant. Thanks, Lena. Over to you, Mike.
Well, thank you very much to all three of you. What an amazing presentation! How interesting to take it through. What is still and like Phil, it seems like I'm a similar vintage to Phil, but that self-discharge continues to be an issue and will always continue to be. And what an amazing way to think of it. For those watching, if you'd like to put questions into the Q&A tab, those that you have, please put them, and we'll put them to the panel. But I'll start off with going to Lena, and I completely agree with Phil. I'd like to ask about capacity. I'd completely agree with Phil that we should probably do a whole session. But just very briefly, Lena, if you were assessing the capacity of a patient, and as Phil says, it's something that we probably just should be doing all the time. What sort of principles do you use as a foundation doctor to assess capacity?
Well, I think I would first start off by making sure that the patient understands what's going on to begin with. Sometimes and it's happened to me before, I come to a patient and then I realize that they don't even understand what's going on and why they're in the hospital or why they need to stay in the hospital for further investigations. So figuring out their understanding of what's going on is important, but also making sure that they're able to retain this information and then say it back to me to make sure that they are fully informed about what's going on, and that can tell me, yes, we're headed into a direction where this patient has a capacity to make that decision.
Okay, and I think I would really commend those watching, as if you're foundation doctors, if you haven't had a session about capacity, please ask your supervisors or your training program directors to put one on. It is so important. It's something that I would probably assess 2 or 3 times a ward round, people's capacity to make decisions. We have an increasingly aging population, which makes capacity decisions increasingly important, and it's something that you really need to become, not just to get some experience of, but as your careers go on, need to just become a normal part of your clinical practice. So I'd really commend you to do those sessions. Thanks, Lena.
Yeah, on that point, Mike, I think it's maybe worth adding that I think the Mental Capacity Act is actually a really well-crafted, well-written piece of legislation, and it does pay dividends to actually go back to the original statute itself. I mean, most statutes are completely unintelligible, but the Mental Capacity Act, sections 2 and 3, really do guide you step by step through the assessment of capacity. And for those listening, it's helpful to remember that the assessment of capacity is a 2-stage test. The first stage is to ask yourself, is there a disorder of the mind or brain affecting your ability affecting the patient's ability to make a decision at the time that the decision needs to be made? And that's a really important first step, because if there is no disorder of the mind or brain, by definition, the patient has capacity. So once you've established that, yes, maybe there is a disorder of the mind or brain affecting their ability to make the decision, then the next section of the Mental Capacity Act is the bit that tells us that we must, that the patient lacks capacity if they are unable to understand, retain, use and weigh, and communicate. And those 2 stages are captured by section 2 and section 3 of the Mental Capacity Act. And if you read those 2 sections, which are just very short paragraphs, but abide by what those sections tell you, it's a very clear reminder and step-by-step guide as to how to assess somebody's capacity.
Thanks, Phil. And in assessing capacity, it is really important to say that as a clinician, patients have the right, and often do, make what we might consider not the right decision, but it's a decision they've made with their capacity, and one must respect that, and not take it personally. They're not making a decision against you; they're making a decision that they want to do. Thanks, Phil. Laura, in the first or not the first principle, sorry, I have listened, in the principle of respect for autonomy, it was mentioned about that under some circumstances it could be or we might need to think about whether it's non-autonomous. The patient actually isn't making an autonomous decision. What sort of things might a foundation doctor look out for just to make them think, does the patient have autonomy here?
Well, I may end up deferring to Phil and Lena, being the medics in the room. I'm always slightly mindful as a non-clinician that they'll know far more about it than me. But I think what we were talking about there was about coercion. Maybe, and I did research, I did a qualitative study speaking to people who had self-discharged, as well as people that the medics, the registrars and the nurses that were involved in that, and so I did gather perspectives on the self-discharge, and I've written a publication about it. And I think that coercion, I'm always a little bit mindful, it can be quite subtle, and it always can be very explicit. So it could be a family member you know, saying you need to get back home, who's going to look after the kids, etc., for example. But it could be more subtle than that, and our research showed that. So there was things that concerns about looking after pets and having to get back for pets. It could be that they are the breadwinner, and if they don't get go to work the next day, there isn't going to be food on the table on that weekend, for example. And so it's exploring that kind of the explicit coercion, which is, you know, family members perhaps saying you need to get yourself back home now. But it could, I would argue from the research that it can actually be a bit more subtle than that sometimes, and it can be a felt burden, a responsibility that they need to get back home for. But maybe Phil or Lena might have more say on that matter.
Yeah, I think it's to avoid confusion for those listening, it's important to separate the notion of capacity from the concept of autonomy.
Yeah.
When we're talking about patient care as clinicians, what we're guided by is whether the patient has capacity or not. Morally speaking, what we're guided by is whether it's an autonomous choice or not. And these are different concepts. Capacity is a legal concept that's defined by the Mental Capacity Act. Autonomy is an ethical concept. And the two, obviously, there's a lot of overlap between them, but they are different. And I think the key things that distinguish them are, as you say, Laura, the issue of voluntariness and rationality as well. Autonomy implies a degree of rationality. There is an abundance of case law and some particularly fascinating quotes from case law that say that patients can make unwise decisions for no reason whatsoever. They can be irrational, but if they have capacity, we must still abide by their decision. Now, irrationality would imply a lack of autonomy, but it does not imply a lack of capacity. And the challenge for us sometimes as clinicians is to differentiate between a capacitous but irrational choice from an incapacitous choice. And that's a fascinating area of discussion for a session on capacity. But the issue of voluntariness, for example, as Laura was saying, doesn't come into capacity. If I hold a gun to your head and say, give me all your money, you don't suddenly lose capacity to make the choice to give me the money. But you can't pretend that it's a voluntary choice. And patients do make choices that are non-voluntary, but still capacitous. And that can be sometimes quite a challenge to untangle these things. And if a patient is making a choice that is capacitous, but not voluntary, and it's not in their interests to be going down the route that they seem to be choosing, that puts us in a really, really difficult position, because we can't invoke the Mental Capacity Act because they have capacity. We really have to stand back and look to other avenues for intervening or persuading. And we had a particularly interesting example came to our ethics committee the other day of just such a case where a patient was making seemingly unwise choices due to coercion from family members. And the question was, what was our authority for intervening and overruling the patient's decisions? And actually, our resources for doing that intervention are extremely limited. And there are some things that you can do under the Care Act, for example, to protect vulnerable patients who have capacity. But ultimately, sometimes you have to go to court and seek request that the court use their inherent jurisdiction to intervene. But it's a fascinating interplay between capacity and autonomy. And bear in mind that the two are not one and the same thing.
Thanks, Phil. And it's really important, particularly for foundation doctors, to remember that if in doubt, they should ask whoever is supervising them, whoever is senior to them, who, as we've heard, may not have a right answer or the right answer, but will certainly be able to help. And you mentioned there, Phil, ethics committees. What is the role of ethics committees, and how could foundation doctors, get involved?
Yeah, absolutely. I mean, to follow on from what you said there, Mike, if you're in doubt as to what you should be doing, discuss it within your team. Go to your seniors and have these discussions with them. They may not have the answers either, but by having a group discussion, you will share ideas. But ultimately, yes, there is also, hopefully, the option of reverting to a hospital ethics committee. And I would encourage any of the foundation doctors listening to find out whether their hospital does have an ethics committee. They will be more than happy, I'm sure, to have you perhaps shadowing them or listening in on any meetings. Just to see what they do. But certainly our hospital ethics committee in Morecambe Bay is, we are more than happy to accept referrals or requests for advice from clinicians of any grade, foundation upwards. And, if there is doubt, there is no such thing as a bad question. If you're in doubt, your ethics committee, I'm sure, would be delighted to discuss it and give you some feedback.
If I can follow on,
certainly be the case for our ethics committee at Morecambe Bay.
If I can follow on from Phil then, Mike, as well, just to say there's the UK Clinical Ethics Network, so UK CEN, and there's the Institute for Medical Ethics, the IME. But the UK Clinical Ethics Network does have a list of all the clinical ethics committees that are active across the country, and they also have annual one-day training sessions, which are they're very clinical, they're very case-based focused. So and you would then, if by attending, you would also get to meet other people interested in clinical ethics. So it's well worth looking at.
Some great resources there. Thanks both, and certainly yes, my trust has a very active ethics committee, and I've referred patients to them for discussion on a number of occasions where I'm not sure what to do. So I really commend people to get involved with that. Well, thank you very much to all three of you for a really quite fantastic session. Really interesting, has brought up lots of different ways of thinking, and I hope that was useful to foundation doctors as they move forward in your career. So I'd really like to thank the three of you for your time and wisdom. I'd really like to thank the UKFPO team for being all the behind the scenes help. We certainly couldn't do it without you. We're hoping to continue these webinars on a monthly basis, so please look out for future webinars on the UKFPO website, and I wish you all the best for the rest of your day. Thank you very much.
Thank you.
Thanks very much for having us.
Thank you very much for having us.